Good afternoon, everyone, and welcome to Family USA's webinar for partners on state health coverage strategies for COVID or coronavirus, COVID-19. Thank you so much for joining us today. We've got a pretty packed agenda, so I'm going to go ahead and get into it here. I'm Lisa Hunter. I've recently joined Families USA as the Senior Director of Strategic Partnerships. I'm looking forward to getting to know each of you as we engage on this issue and certainly others. In any way I can be helpful or the team here can be supportive, please don't hesitate to reach out. I know this is quite a lot that everyone is navigating, and we're immensely appreciative of your partnership and interested in staying in touch and engaged with each of you and all the work you're doing on behalf of families, consumers, our most vulnerable populations. So with that, as you all know, we are finding ourselves in a brave new world and working hard to understand how we can all best respond to COVID and all who are affected. For today's webinar, we have several aims, including making sure that each of you is armed with actionable information and resources, such as our state strategies document that we issued earlier this week. And that document is available on our website under the Resources tab. And we will send that back out after the webinar as well. Second is that we at Families are learning from you all about your on-the-ground needs and the lessons learned, and also giving you an opportunity to hear about the experiences of others. And then third, we want to use this as an initial opportunity to inform future potential federal and state advocacy. In terms of the agenda, it's pretty packed, and we are going to kick it over in a moment to Elliot Fishman, our Senior Director for Policy, who's going to provide an overview of the federal activity that we've seen over the past several weeks, which has really laid the marker for further policymaking within the states as well. Joe Weisfeld, our Director of Medicaid Policy, will discuss state policy options available under Medicaid. Cheryl Fish-Percham, our Director of Access Initiatives, will discuss options within the private market. Suzanne Curry is joining us from Healthcare for All in Massachusetts to give us a sense of some of the work they've done in response to the pandemic thus far. And then we'll have an opportunity to answer questions, and we also have Stan Dorn, the Director for National Center for Coverage Innovation at Families, who can also help us answer questions as they come in. But before I turn it over to Elliot, I'm going to go through some housekeeping. So again, this is being recorded. The slides will be made available. And when it comes to the Q&A portion, we are asking you to please use the chat box function. The presentation will continue to run through, but if you have questions that occur to you in the middle of the webinar, please go ahead and use the chat box to submit questions, and we'll turn to those questions after we've gone through the presentation. Additionally, at the end of the webinar, we're going to be sending you all a survey where you can submit additional questions in case we run out of time or questions you'd like us to answer separately. The survey is also important because it's going to gauge future ways that we at Families USA can be best supporting each of you and your work navigating these times. So please take a moment to fill it out. It's not long, and will help inform how we can be how we can best serve you moving forward. And with that, I'm going to turn it over to Elliot.
Thanks, Lisa. I'm going to start by introducing federal opportunities. We'll be going through these in more detail really throughout the webinar today. I'm just going to lay out the basics. And I'll start with new state flexibilities that the Centers for Medicare and Medicaid Services and the Department of Health and Human Services have put out administratively under National Emergency Authority. Then I'm going to go through the new opportunities for states and new funding streams for states under the two major bills that have been passed. For the first one 2 weeks ago, the second one was just passed today. And those also have significant implications for states. So first, the significant new flexibilities that states have under the national emergency. States can submit Section 1115 waivers. Those are the classic Medicaid waivers under emergency authority, they can submit waivers without the long process that is typical of Medicaid 1115 waivers of proposing a draft, getting public comment at the state level, getting public comment at the federal level. That can all be expedited with federal permission under the national health emergency that was declared. There's also an exception to the federal requirement that waivers be budget neutral. So, for example, if a state wanted to do an 1115 waiver that in some way expanded coverage for COVID treatment to uninsured populations, it would be hard to make a case that that is budget neutral. That's not necessary using this emergency authority for an 1115 waiver. Second thing a state can do under the Stafford Act declaration is to submit a temporary state plan amendment. And you can do a lot with state plan amendments. You can, very importantly, expedite eligibility determination so that that is close to an immediate and seamless process. That's very important when you think about the number of people who are about to lose employer coverage, and we're going to be talking a lot during these slides in general around the importance of getting support and quick coverage opportunities for the millions of people who just lost jobs and need alternative sources of health coverage for their own health and really as a matter of urgent public health. We have some examples here of, in general, of the kinds of state plan amendments that are eligible for this temporary emergency status. States could suspend the annual redetermination of Medicaid. Some states have already begun to do this, and Joe Weisfeld will be talking about that in a few minutes. For optional Medicaid populations, so these are populations that are not mandatory but don't require an 1115 waiver, those are also eligible for temporary state plan amendment coverage. I'll put in parentheses here, that doesn't include expansion adults. States always have the ability to turn on or turn off coverage for expansion adults via SPA. So, and again, we can talk about this during the Q&A, but effectively, states always have the ability under CMS guidance to temporarily cover expansion adults if they wanted to frame it that way in a non-expansion state. The third type of state flexibility that is opened up by the emergency declaration is called a Section 1135 waiver, and that is a public health emergency waiver authority. The kinds of topic areas that fall under that Section 1135 authority tend to be more tied to the health system. So opening up the health workforce, enabling more physicians to or other providers to be able to practice. And again, we'll go into more details on these in a couple of minutes. This slide just is an example of the sort of information that is being made available by CMS. So this is on the state plan amendment flexibilities that I referenced in the previous slide. But if you look under that blue banner where it says resources for states, you'll see there is a disaster response toolkit. This is one of the sub-pages on that disaster response toolkit. But we would suggest that folks who are on this webinar check out this information. This is on Medicaid.gov's page, which is a good detailed source of information. So there are also new funding streams that have been opened up for states under the two major pieces of COVID-related legislation, the Families First Act. We at least in the DC area, have taken to calling that COVID 2. COVID 1 was just the initial tranche of money that went to CDC. The Families First Act included a 6.2% increase in the federal matching percentage for Medicaid, and that was tied to a state maintenance of effort requirement. That means that states cannot pocket that increase in federal match and then just go ahead and cut Medicaid. And that maintenance of effort requirement had 3 parts. We fought hard to preserve those 3 parts this week, and we certainly hope that everybody on the phone and online is aware of them. The first part is a familiar maintenance of effort that just says that states cannot reduce eligibility for Medicaid or reduce Medicaid benefits while they are receiving this enhanced federal match, and the baseline for those is the beginning of the calendar year. The second, which is a newer piece and the piece that was at risk this week until we beat back the effort to challenge it, was that states need to suspend disenrollments from Medicaid for the term of this national emergency as a condition of receiving those funds. And the policy rationale for this is very straightforward. While there is a national emergency going on, and while enough people are losing their private health insurance, their employer health insurance, the last thing we need to be doing is throwing people off of their Medicaid. But this is just something that we all, as advocates, need to be monitoring compliance with. So states should not be disenrolling people at annual redetermination or otherwise while this enhanced match is in place. The third piece only affects a few states. Those states that charge premiums under Medicaid cannot increase their premiums while receiving this enhanced match. The next piece of legislation, the CARES Act, which just passed the House a couple hours ago, involves 2 relief funds that are distributed through states, a $150 billion coronavirus relief fund and a $45 billion disaster relief fund. We are awaiting federal guidance on both of these, but just note that I think the health advocacy community is perhaps not as used to tapping into these kinds of disaster funds. But this is, of course, a health disaster, and while we await federal guidance, it's almost certain that it's going to involve spending for health access of one kind or another. The statutory language is very open for the larger fund, the Coronavirus Relief Fund, and we are keeping our eye on it as a potential source of funding for outreach and enrollment help to laid-off workers. That is a huge priority. It is very hard to reach and assist people who are going through a layoff, especially in the midst of social distancing and all of the concomitant stress of losing a job and a nationwide pandemic. To reach people and help them sign up for insurance, we see that as an important target for any kind of state funding priority, and certainly a potential target for the Coronavirus Relief Fund. Supporting Medicaid and safety net providers who may be losing alternative revenue streams as people do not go for elective procedures or even relatively non-elective things that they should be going for but are not able to. And we're also thinking about the Disaster Relief Fund as something that could pay for non-hospital care for uninsured people. It should be noted that in none of these pieces of legislation was there much help for immigrants. Both documented and undocumented immigrants were missing in some of the benefits expansions in these bills. For example, even the coverage, there's a state option to cover screening and testing for COVID for uninsured people. It's specifically for uninsured people. However, not only does it exclude undocumented immigrants, it excludes many lawfully present immigrants. It's limited to the qualified subset of lawfully present immigrants, and there are resources available on that from Protecting Immigrant Families, among others. But that is a major gap in this specific channels of funds that were made available under the two pieces of major COVID legislation, and it is possible that that is a gap that states can fill using these relief funds. Certainly something important to keep an eye on. And with that, I'm going to hand things off to my colleague, Joe Weisfeld.
Great, thank you, Elliot. Great information with what's happening on the federal side. And while those federal debates were happening, many states had already been leveraging their existing authorities in Medicaid to meet their residents' needs, and will continue to explore the additional opportunities in light of all the different pieces of legislation moving through the process. I'm going to focus on 5 buckets of activity. I probably could spend the whole hour just on Medicaid, but I'll likely just focus on select activities within each of these buckets that you see on your screen. They're around expanding eligibility, making it easier to get and keep Medicaid, eliminating barriers to coverage, improving access to providers, and expanding services within the Medicaid construct. One note of importance, and Elliot hit on this a bit, a good chunk of the state's efforts to eliminate barriers to coverage were codified in that maintenance of effort provision that Elliot mentioned. So states are getting a 6.2% additional federal matching percentage in their Medicaid expenditures from the federal government. And with that bump is that maintenance of effort provision, which does provide pretty major protections to beneficiaries. And I'll go into that a little bit more in depth in just a little bit. So first, expanding who is eligible. Like Elliot mentioned, there is great opportunity and pressure for the remaining 14 states to expand their Medicaid programs that could quickly protect 2.3 million uninsured adults who are not eligible for subsidized health coverage in the marketplace, and millions more who would qualify in the coming months due to job loss and loss of their employer-sponsored insurance. I want to highlight just a few states in particular that are either recently expanded or close to expansion that really are well positioned to improve or to stop stalling and just expand. So Nebraska, who passed the ballot initiative in October of 2018, in November of 2018 still hasn't expanded. They're ready. They could expand if the governor decided to up the date. We have Utah, who just expanded in January, but that's a state where there could be a lot more outreach to individuals to enroll and up their enrollment numbers. And then you have Oklahoma, Missouri, Kansas, who all have momentum and are moving towards expansion, and a real opportunity to move forward without conditions and just expand Medicaid. But there are a few other options as well. The disaster SPA that Elliot mentioned gives some temporary options, which includes extending eligibility to some individuals over 133% of the federal poverty level, with populations such as pregnant women and kids really being key populations that could temporarily get bumped. Those populations also could get permanently increased eligibility thresholds, children, pregnant women, as well as states taking up the option to eliminate the 5-year waiting period for legal permanent residence for children and for pregnant women. 17 states have already done, 17 more states could take up this option for children and 26 more for pregnant women if they wanted to do that permanently. And lastly, as Elliot mentioned, the second COVID package had a state option to cover the uninsured, and that uninsured definition is very broadly defined. It can include immigrants. The coverage, however, for this new population or eligibility group in Medicaid is for COVID testing and related services, so it's not necessarily for treatment and beyond, but for that testing and related services, the feds will finance that at 100% federal match. So moving over to making it easier to get and keep Medicaid, the big ticket item here really is the MOE. So effective, in order to receive that 6.2% bump, states have to maintain their eligibility and policies as of January 1. So again, like Elliot mentioned, no increased premiums, no cost sharing related to COVID. There is no terminating beneficiaries, which I think is really, really important here. It doesn't stop states from going through the redetermination process and checking eligibility, but if any information comes out that would normally result in termination, the state can't act. The only terminations that are allowed are voluntary terminations or changes in residence where an individual has moved out of state. Additionally, if a state has already terminated a beneficiary as of March 18th, the state has to make a good faith effort to identify and reinstate that individual. And importantly, this does not stop states from doing the opposite, from making temporary or permanent changes that are less restrictive. So they can lower premiums, they can ease verification requirements, and they can streamline the application process. CMS was quite clear about that in their guidance. And then there's just a couple other pieces I want to talk about. Presumptive eligibility is one that I think has a lot of promise during this period. States can offer uninsured individuals immediate temporary Medicaid if they appear eligible based on income. A lot of states already do this for select populations. 20 states do this for children in Medicaid, 11 for CHIP, 30 for pregnant women, 9 for parents, and 6 in the expansion population. States who don't already do this can permanently do this via SPA. Additionally, under the disaster SPA, there's some temporary opportunities here. State Medicaid agencies have some interesting options. One is they can become a qualifying entity to determine presumptive eligibility. Typically that's done through hospitals, but this would give the Medicaid agency an ability to identify folks more quickly. Additionally, under the disaster SPA, some of the populations that typically are not eligible for presumptive eligibility, seniors, individuals eligible based on disability, temporarily could be eligible for presumptive eligibility if a state elects to follow that option. And then the last two in this area, one is under continuous eligibility for kids. This is already a state plan option for states to do permanently. Disaster SPA would also allow a temporary 12-month continuous eligibility option. This presumably, if the disaster period is less than 12 months, this option would actually exceed the MOE protections and outlast the national emergency if states elected to do this on a temporary basis. And finally here, the states that have requested waivers to waive retroactive eligibility, that is the federal requirement that states provide 3 months of retro coverage, those states could undo that. Utah could decide not to implement their waiver. Nebraska could withdraw, and then Arizona, Florida, Iowa, and Indiana could reinstate retroactive, which would give an ability to ensure continuity of coverage and services for many, many individuals. Moving on to other barriers, again, a lot of these are protected in the maintenance of effort provision, but states can and should eliminate premiums. Arizona and Iowa have actually proposed waivers already to suspend these. The disaster spa also could pause these premiums. States can't increase them, but there are opportunities to also get rid of these. On work requirements, Utah is the only state that has an active work requirement program right now. It sounds like they're considering pausing. They absolutely should and can and have the flexibility to do exactly that. And then I want to highlight two of the most common provisions that we've seen states do administratively prior to the most recent federal legislation, and that is relax prescription refills, allow early refills, permit 90-day supply, and also use prior authorizations. This one really is a state-specific opportunity, but your state has the lever, whether it's through a SPA, an 1135 waiver, a disaster spa, or even just administratively done. Moving on to improving access to providers, I want to talk about telemedicine because that is one of the areas where it really seems like the states have acted so quickly, quicker than CMS and Medicare and the Hill really have been able to react. And they're doing it in very, very innovative ways. So Medicaid already was very flexible when it came to telemedicine, and the states have taken advantage of extending that quite a bit. Notably on telephonic only telemedicine, so just using the telephone. We count at least 36 states, including DC, have already temporarily allowed this option to reimburse on Medicaid for telephone-only services. Additionally, we're seeing more and more allowing of home as the originating site, which is something that most states, Medicare, commercial, have had some levels of restrictions over time. We're really seeing now through the federal legislation that more and more payers are going to probably follow suit in following Medicaid's lead. And then on provider participation, the 1135 waivers that Elliot mentioned are really the lever here. We now have 34 states as of today that have received these waivers. During the national emergency, what they allow are things like easing of provider screening requirements or allowing out-of-state licensure, allowing providers with out-of-state licenses to practice in the state. They can postpone the deadline for revalidation of providers. They can allow services to be conducted in unlicensed facilities in certain circumstances. It also allows suspension of prior authorizations and flexibility on appeals and hearing timelines. And then the last piece I'm going to talk about is expanding services. Here there's a provision called Appendix K, which is part of the home and community-based waivers, the 1915C waivers. In emergencies such as this, those services under those HCBS waivers can be expanded, modified pretty quickly. And so far we have 7 states that have done this, and a lot of those are around increasing eligibility incomes for the program, increasing services, allowing home-delivered meal, remote patient monitoring and telemedicine for services in those individuals' homes. I think we'll see more and more states take up this option in the short run, as it is a pretty simple process. And additionally, we've seen a little bit on the housing front as well. Arizona, California, and Massachusetts have all asked for Medicaid to pay for temporary housing during this emergency process period. I'm sorry. And then I'm going to wrap up with an example from my home state of Ohio, so a lot of pride here, just to show what states can do. And so Ohio, as of yesterday, announced that they are extending the redetermination period So effectively, anyone who was going to, their Medicaid or SNAP was going to expire in the next 6 months will automatically be renewed. The individual themselves does not have to reapply. So that really shows an example how states can take the lead here and make sure that Medicaid coverage is offered and sustained. So I'm going to stop there and pass it along to my colleague, Cheryl.
Thanks. I'm going to now shift gears to talk about people with private coverage and trying to make sure that they can get decent coverage and coverage in the marketplace during this crisis. So first, I want to talk about making sure that they can enroll in the marketplace and retain their coverage. And then after we go through some of the specific private insurance options, then we'll talk about just enrollment generally. So one of the things that's really important about this is that although insurers can take action on their own, and you've been reading in the news about insurers volunteering to do various things, you can, as a state advocate, push to make sure that these are universal requirements and that either the state insurance department or your state exchange, if you're operating a state-based marketplace, or your legislators are ordering that these various policy options apply to all private insurers that the state can regulate in your state. So the first thing that they can do to ensure that people can get enrolled in a marketplace plan right now that includes financial assistance for people with low and moderate incomes is to create or extend a special enrollment period. And we hear that the federal marketplace is going to be opening a special enrollment period. And you may know that anybody who loses job-based coverage is entitled to a period of 60 days to enroll in a marketplace plan. But it's important that there be a sort of universal open enrollment period at this emergency time. It's much easier to publicize that there's open enrollment and everyone can enroll than it is to say, oh, if you've lost your job within 60 days, you might be able to enroll in a plan. So that's why we're urging states to consider a special enrollment period for everyone right now that just reopens their state-based marketplace. If you're in the federal marketplace, of course, you don't have that right. It's the federal government that can open that enrollment period. But be watching for that to happen, and you can help publicize it when it does so. You may know that in the new CARES package that is going through, that has just been approved, there's a $600 weekly unemployment check that people will be getting from the federal government. And I just want to stress that that check will not count as income when people apply for advanced premium tax credits. The next thing that states can do is to prevent plans from canceling due to non-payment of premiums. And I've seen that some insurers have already announced that they're not going to cancel plans due to non-payment of premiums. And CMS, in guidance that it put out today, also said that they would help plans to not cancel or allow plans to extend grace periods for people paying premiums so that they won't be cut off if they miss a payment, and so that initial coverage can start if they haven't paid their premiums yet. So all of those things are allowed, but state regulators can do more to actually require that plans don't cancel benefits at this time. The DC Insurance Commissioner is one that has taken action by ordering that all plan cancellations be subject to the insurance department's review before they go into effect. The next thing that states can do goes into the bucket of limiting cost sharing. And you may know that in the federal legislation, there is already a requirement that testing for COVID be pre-deductible and no cost sharing. But that is still a limited right in the federal package, and states can do more to assure that both testing and treatment be free to privately insured consumers by making it pre-deductible and by eliminating cost sharing for those services. New Mexico has gone further by saying that conditions that are related to COVID, like pneumonia and flu, that might mimic COVID symptoms, and so they need to be ruled out by testing, that needs to be also pre-deductible and no cost sharing. And DC, Massachusetts, and New Mexico are states that have said that COVID treatment is also free to privately insured consumers. I saw some questions in the chat box about the $600 unemployment bump, and so I just want to repeat that for premium tax credits, the $600 weekly unemployment check does count as income. The $1,200 rebate checks that people are going to be getting does not count as income. For Medicaid purposes, at the moment, the 600 weekly unemployment check will not count as income. So that's very confusing, but I just and we'll send that out also in writing after this call. As Joe mentioned, telehealth is a really important service right now. States can also make sure that telemedicine is free from cost sharing, and many insurance plans have voluntarily taken that step. Another thing that states can do is prohibit surprise bills. Of course, if you're in the hospital seeking COVID treatment, the last thing you want to do is find out that all of your treatment is out of network. And so it's really important that states act to make sure that people don't get out of network bills right now. Certainly the states that already have surprise bill laws have done that. Other states can step up, especially right now with the COVID-related services. The District of Columbia is one that has issued an order specifically about COVID-related services that holds consumers harmless from surprise billing. Many consumers are looking to buy any kind of insurance, and you won't be surprised to hear that short-term junk plans are continuing to market to consumers. Brookings did a blog this week that you can find where they, interviewed brokers about whether the short-term plans that they were covering were going to cover COVID treatment, and of course the brokers all assured them totally wrongly that the plans did provide comprehensive coverage for COVID testing and treatment. It is a very dangerous thing if consumers get into these plans. A couple of things that states could do are, again, prohibit short-term sales altogether. If short-term plan sales are allowed, Washington issued an order that they had to cover COVID treatment and testing, or New Mexico issued an order that said that they have to send out a specific notice to consumers right now saying that they might not be covering that service and directing people to where they could get comprehensive coverage. Now I want to talk about the bucket of eliminating barriers to service. There are different things that states can do to make sure that there's not a barrier to getting services, like waiving prior authorization requirements. And Commonwealth Fund has a blog that was linked in our piece, a tracker rather, that our friends at Georgetown are keeping up, that keeps track of all of the states that have waived prior authorization in private insurance and have done many of the other things that we're talking about today. So you can consult that to see if your state is among those that are waiving prior authorization. States can also relax prescription drug policies to make sure that there's no restrictions on medication refills and that there are no charges for home delivery of drugs. They can require full reimbursement of telehealth. We mentioned telehealth before. Telehealth is an especially important service for behavioral health at this time when people are isolated and afraid and likely to have other problems. And many mental health groups are very conscious of ensuring that payment parity exists and that mental health parity exists. So that's something to check on in your state and to check with the mental health and behavioral health groups in your state to make sure that those are going well. So then the last bucket that I want to talk about is about improving affordability for marketplace coverage. And we know that Suzanne Curry, who's going to talk in a minute, has in Massachusetts is a real model of improving affordability. So is California. Other states have taken action to enhance the premium tax credits that are already available in the marketplace to make sure that there is more robust assistance to people. Now I'm going to turn to enrollment options, and here I actually have questions that I hope we get to in the chat time. One is that we would like there to be a one-stop place where you can publicize on all of your state websites that reach people, that they can go to this one place to figure out what insurance they're eligible for. And of course, the health insurance marketplace is supposed to perform that function and screen for Medicaid eligibility as well as for marketplace eligibility. We know that that hasn't been a reality in all states, that in some states there were delays before you actually get Medicaid processed if you go into the marketplace first. And so we would love to know what's the story in your state. Is it good to direct people to healthcare.gov as their first stop when they are looking for coverage? There should definitely be robust consumer assistance at this time. We need enrollment hotlines, we need navigators, we need telephonic Medicaid help, and we'd like all of those things to be funded, and that's something you can fight for at the state level. You can partner with workforce agencies to make sure that their messages are loud and clear about people's rights to enroll in coverage, whether it be Medicaid, the marketplace, or a job-based plan from another family member, or COBRA. And you can creatively finance that enrollment help by looking for insurers and hospitals who share an interest in getting everybody covered to also contribute to funding for what would be a win-win effort if everyone gets covered. And with that, I'll turn it over to Suzanne.
Thanks, Cheryl, and thank you to Families USA and for everyone for asking me to join today. And I think, to be honest with you, I think we've made good traction, and I think we can do a lot more. I was actually just taking some notes of things that we should definitely be proposing as you guys went more in depth, and I did read sort of the brief too, so I think there's more that we can be doing in Massachusetts. So like many of you on the call, we've been working with state policymakers, both in state agencies like Medicaid and the Division of Insurance, and with the legislature as well, who there are some working groups within the legislature who's actually really focused on also communicating some gaps that remain to the administration, so to be an amplifying voice in some of the things that maybe we weren't able to push forward. To help people maintain or get access to not only COVID-19 related services, but their other existing and emerging medical and behavioral health needs. And, you know, like many states, there is a kind of clearinghouse website where there's a lot of information there, and you can get information about what the Medicaid agency and the Division of Insurance have put out, which I'm sure, like many of you, has been changing on a daily or even more frequent basis. So to date, there have been several of the policies that Cheryl and others have talked about that have been put into place in Massachusetts, but we can definitely learn from other states and go even further. I'm just going to run through a few things of kind of like what's we've suggested and has been put into place, and then some things that we're working on with the state, particularly relative to supporting enrollment assisters and also messaging to specific communities like immigrant communities. So on the Medicaid end, our Mass Health, as our combined Medicaid CHIP program, has taken advantage of the FMAP increase, or will be hopefully, in suspending downgrades, terminations, and they're suspending renewals and basically just blanket protecting coverage until the end of the state of the emergency in the state, or the national emergency, which becomes whichever's later. So the coverage is protected there. Unfortunately, we don't have kind of like a regular presumptive eligibility system, but we are expanding hospital presumptive eligibility to more people, including those who've already gotten a determination through hospital presumptive eligibility in the past 12 months, and are doing what many other states are doing around covering telehealth for all covered services that are appropriate to be delivered that way, and but will be paid at the same rate as in person, and this is the same for commercial insurers as well. And also with respect to kind of allowing for medication access 90 days and early refills, doing that as well. With respect to telehealth, our Medicaid agency also oversees our health safety net, which is our uncompensated care pool. And there was just guidance that was released, I think yesterday, I can't keep track of the days, allowing for compensation for providers for providing telehealth services to folks who are covered by the health safety net, which is folks who don't have access to other insurance. So it includes large immigrant population, but some others as well. And things that have been requested to the agency but have not been implemented yet include presumptive eligibility for seniors, which was discussed. And unfortunately, we are one of the states that doesn't have 12-month continuous eligibility for kids. You think we would, but we don't. So that's one of the things we're trying to take, the opportunities we're trying to take advantage of right now. With the exception of the special enrollment period, which we did put into place in the state through April 25th, the Division of Insurance released many bulletins which were related to some executive or emergency orders that the governor put into place, although there's sort of a disconnect between the wording the governor used in the DOI bulletins, because the DOI bulletins often say that they expect insurers to do such and such thing as opposed to require. So we're looking for some strengthening there, but I think the meaning is there, such as the no cost sharing for COVID-19 testing and treatment, although we need to make sure there's a clarification that that cost sharing includes deductibles and coinsurance for the treatment piece. It's clear for telehealth for some reason, but not as clear for in-person, so we're pushing DOI to change that language. Encouraging flexibility for premium payments for both employers and consumers. And I think we want to take a nod from DC there and maybe go even further. We had suggested a kind of blanket sort of grace period without any sort of retro termination, but that had not gone into place either. Telehealth as well, kind of saying both the providers and the payment and access to prescription medications such as early refills, and continuing to make sure that folks get their mail orders. There's another piece that we had suggested to our Division of Insurance, which was around kind of proactive and additional messaging to consumers, to members, just about all these different policies that are in place, and I know they're on a rolling basis, and they did just come out with a bulletin with an expectation that each insurer have a dedicated line, which would probably just be like when you call into the insurer, you press a number to talk about things with them, and it won't be a separate line, but it would be under their customer service line to get additional information about COVID-19 related guidance and information, as well as posting additional things to their websites, using text messages and other things to make sure that people understand what the insurer is doing with regards to both COVID-19 testing and treatment and the assistance there, as well as some of the other policies. And so that's something that's going into effect as well. Something that's interesting that the Division of Insurance is doing is encouraging insurers who act as administrators to talk with plan sponsors, so employers who have self-funded plans, about the importance of implementing these policies as well. So while they don't technically have purview over those plans, they're really encouraging them to follow suit in those policies. A few things that we're hoping will happen, but we're not sure, are with regards to telehealth in the private market. It talks about in-network services, but there's no mention of out-of-network arrangements. So we want the Division of Insurance to make clear that current out-of-network arrangements that people have are honored via telehealth. And we want to make sure that they strengthen the premium flexibility, as I mentioned. So DC is a good example of that. We're looking for more kind of flexibility also in payment dates through the exchange, through the marketplace as well, which they're looking into and we'll be working with carriers on. With regards to a couple of other things, the proactive messaging to immigrant communities, I think, is a particular challenge. There's not as much information out there, and as challenging as it is to get information out to folks whose first language is English, it's even more difficult in immigrant communities. So I'd love to hear from folks what you're doing on that end. We sort of developed an FAQ with our partners here in our PIF Massachusetts group, around a whole host of issues there to work with, distribute to community leaders in different immigrant communities. But it seems like there needs to be more efforts there. And then outreach and enrollment here, as people are kind of losing their jobs, we run a helpline at Healthcare for All, and that, we're pretty overwhelmed with getting a lot of calls with folks who are newly unemployed and have lost their health insurance, and helping them navigate that. We have been a helpline, and even our staff going remotely was sort of a challenge with the technology. So part of what we're doing is trying to work with the state to figure out how to support other enrollment assisters to be able to provide remote assistance, so they can, a lot of them are based at hospitals and community health centers. How can they basically work from home and make sure that the folks who need to call can call and get that assistance? And so we're working with the state on some plans around that. I don't have anything, unfortunately, to add at this point, except that we are doing a survey of a large group. We have kind of this online community of 850 enrollment assisters who we're currently surveying to see kind of what the challenges are that they're facing right now, including remote assistance. And so that's, I'm going to stop in one moment. One of the other things is just, would love to hear from folks other outreach and enrollment strategies that you're using right now, given that there's not the in-person or other capabilities that there normally are. And I know that there are, in our state, since we haven't done telehealth as much, providers are trying to get up and running with that. And I know there's continually many questions about that, even though they're the policies are very liberalized. So would love to hear from folks on the call if there's time about that as well. So I'm going to stop there, and hopefully I covered what I was meant to cover, but if I didn't, please let me know, Families USA folks.
That was excellent. Thank you so much, Suzanne, for participating and for giving us your on-the-ground experience. I think we are all very interested in understanding some of the experiences that you've had, but also other partners across the country in serving everyone from immigrants to other vulnerable populations at this time. So this is really helpful. Thank you.
Thanks.
This has been a very, so if you are not currently on the interfacing with us on the chat box function, folks have been submitting some really great questions. We are painfully aware that we've got 5 minutes left. So what I am going to do is I'm going to commit to this group right now that Families USA is going to take all the questions that have been submitted thus far in the chat box function. So please shoot those over to us, and we will create an FAQ document and do our best to address each and every one. And in the meantime, I'm going to ask our experts that we've got on the phone from families and also Suzanne, to the extent that you're comfortable. I think one of the big things is, given where each of you sits, what are the levers, if you can concisely bucket out the levers within Medicaid, within the private insurance market, et cetera, what are the levers that are actionable right now for partners to protect and best serve these communities and these consumers and families who are going through this really tremendously difficult time with unemployment, changes in their coverage, et cetera. So I'm going to start with Stan and give you the first bite at the apple at answering that question as to levers.
Sure. In terms of the money that is now going to be available, $145 billion COVID, $150 billion fund for states and localities. Local governments' chief executive officers can propose uses of funds and make certifications and draw down up to 45% of the money. Governor's offices presumably will be on the lead for the states. In terms of the $45 billion Stafford emergency and disaster money, I would say a first place to look is emergency management agencies in your state. Ultimately, it may be the health agency that determines things, but it's the emergency management folks who will sort of be on point for that. And the only other sort of thing outside everybody's normal operating procedure would be working with unemployment insurance agencies who are overwhelmed right now. And people just, I think the highest leverage thing to do would be to get a question added to the unemployment insurance application form through which people can consent to have their contact information sent to a health agency who can then reach out to them and sign them up for coverage. Those are my lever ideas.
Excellent. Joe, Elliot, Medicaid, or Cheryl, anything to add?
Yeah, I'll just say really quickly on Medicaid, the Medicaid agency and the governor's office, they have so much flexibility to do things and do things quickly, especially with a lot of state legislatures being out of session and not being able to do things in person. Those are the places that you can go to. CMS is talking to all the Medicaid directors 2-3 times a week at least, so that's where the action's happening.
And on the private insurance side, the insurance department can either issue orders or regulations or both, and also the state benefits exchange, the state-based marketplaces. Of course, legislators are always good.
Suzanne, do you have anything to add?
I don't think so. Those are all really good ones.
Admittedly, I will say I think we are pretty much at time here. I will say we're deeply and immensely grateful for you guys joining in today. Again, try to get some of your questions in under the wire here on the chat box function. I've also pulled up our information here, the info@familiesusa.org. Inbox is being actively monitored, so please get those questions into us. We've got a lot of really great stuff here on everything from telemedicine to coverage to SEPs, so special enrollment periods. And what we're going to do is, again, pull this into an FAQ document and make that available as soon as we can get answers to each of your questions. In the meantime, if you have something pressing that you'd like Families USA to be working with you on, please don't hesitate to reach out to us. And similarly, if this is something that is helpful to you and maybe we do a more concentrated webinar next time, if you would like us to do a webinar, we'd like to know that. If there are specific topics that would be particularly helpful for you tactically and strategically and through giving you some more resources, we're open to that as well. And certainly some of you have also asked questions in the chat box already about where to find information about the status of current waivers, who's asked for them, what's been approved, what has happened in some of the states that we referenced earlier in the presentation. I know some of us have already answered those questions in real time in the chat box, but we can also make those links available to this group as well. thank you again to everybody for participating, for joining. Thank you to our presenters for going through all of this information. I think this is a really critical time to be doing all of our work. And we're immensely grateful for the partnership and collaboration and sharing of information. And we hope to better serve you in the coming weeks and months that we know this will continue to be playing out. So thank you again. And with that, I think we will close.